When you keep older people on lithium, you reduce their future risk of dementia by 49%. 49%, almost half. If you have a history of mania, you have 3 times higher risk of dementia than the general population. Some of that is due to cardiovascular issues, which are in higher proportion among patients with bipolar disorder. But another factor is the cognitive hit that you take from each manic episode. This contributes to that threefold higher risk of dementia. But if you keep older individuals with bipolar disorder on lithium, you reduce their future dementia risk by almost 50%. And no other drug does that at all. Here's a study which tried to compare lithium versus valproate. This was a prospective study. They took individuals who were bipolar disorder, who did not have a dementia diagnosis. They followed them prospectively in their charts from the time they were on lithium or valproate. Anticonvulsants had no protective effect on future dementia risk. Even with as little as a year of exposure, you already started to see the impact of lithium. But it does take time. It's not instantaneous. But once a person is on lithium for more than a year, you're already accruing the neuroprotective benefit, and that's seen in these individuals as decreased risk for future dementia. Well, we like to blame a lot of things on lithium, but I want to make the point here that it's also the population who's at risk for renal dysfunction. And that's something we really didn't appreciate and didn't really parse out until recent years. If we're going to talk about renal function, you got to know how to use the appropriate terminology. This is the modern terminology for talking about renal function. I don't care about anyone's creatinine, really. I don't care about serum creatinine. I care about their GFR, and these are the various stages of chronic kidney disease. Do not talk about lithium causing renal failure. It's a rare outcome, and it's probably due to somebody not monitoring the patient properly. I also give you some comments here about albuminuria. Lithium does not typically cause problems with albuminuria. This is something which is a proximal problem in the glomerulus, typically due to hypertension, prediabetes, and diabetes. The reason I mention this is that you might want to monitor this from time to time because you may have patients who have those comorbidities, but everyone's going to want to blame the lithium for the problem, but the problem may not be the lithium, the problem might be the poorly controlled diabetes or hypertension. Excuse me. The idea that bipolar patients have higher rates of chronic kidney disease risk factors had never really dawned on people when they wanted to blame everything on lithium. But now we understand that. And this is the study which really quantified the issue. This was done from Denmark, where they have great data on everybody. They looked at the risk for chronic kidney disease in the general population, 1.5 million folks. Then they looked separately just at those who had a bipolar spectrum diagnosis. And this is what they found. In the general population, you had certain rates of chronic kidney disease. They were threefold higher in people with bipolar disorder, regardless of what definition they used, whether it was an ICD code or other metrics. Threefold higher. And not all these people were taking lithium. It's the population themselves who contributes a lot of the risk for chronic kidney disease. And that was proved by an analysis of those who were either on lithium or an anticonvulsant, which mostly was valproate. These people with valproate had higher rates of chronic kidney disease than their age-matched peers. We don't think valproate causes a lot of kidney dysfunction. It's the people themselves and their comorbidities which are contributing to this problem. And that's why we've now reassessed the independent contribution of lithium. And this is one of those studies which illustrates that point. They looked at individuals in their early 40s who were starting de novo a medication for bipolar disorder. They followed them for a couple of years with a range. They looked at changes in GFR over time in people who were on lithium or the comparators. Who are the comparators? Quetiapine, olanzapine, and valproate. After they adjusted for demographic factors such as age, medical comorbidities, and of course baseline renal function, and episodes of supratherapeutic lithium levels, they found that the mean annual change attributable to lithium was about 1 ml per minute, compared to 0.4 mLs per minute for a comparative. So you can do the math. The difference was 0.6 mLs per minute per year. This difference was not statistically significant. That attributable to lithium alone, you can see, was really a fraction of an ml per minute per year. I'm not saying that lithium does not have renal adverse effects. It certainly can. But once we appreciate that some of what we were blaming on lithium had to do with the patients we were treating, it's called confounding bias. We now realize that maybe when we use lithium the right way, it's not as bad as what we thought.